Hey guys, this is a sample of one of our amazing lectures found at EMSConnect.org. If you want to see the whole lecture as well as get continuing education credits for your EMS certification, head over to www.emsconnect.org.
Modern shock resuscitation guidelines. So again, follow your local protocols. We are going to talk about shock. So these are your learning objectives that by the end of this, that we're going to check every one of these boxes. Just to go through here to give you a course outline regarding this, we want to start with the foundations of what is shock. So define the pathophysiology regarding this. How do we recognize shock? Utilizing not only our vital signs, but using exam and our pre-hospital tools. Discuss the classifications of shock and medications that we use to treat this. And then the second half after intermission, we're going to go through case specifics and put it all together, the identification, diagnosis, and treatment of each shock type and state. And then lastly, we'll just finish up with a little closing of the integration algorithm, takeaways, and any questions. But please, if there's anything along the way, please stop me, ask questions. That's how we all learn. All right, start this off. If you have anything in medicine, just understand it comes down to these three truths. And if you correct these, you are going to take great care of your patients. So understand air goes in and out, blood goes round and round, and the brain and organs need oxygen, glucose, and a means to get there. All pathophysiology will be affecting one or more of these things. And if you understand this concept and how to address and correct it, then you are going to take great care of your patients. Okay. And we'll kind of circle back to this as we go through each shock state. All right. So, question one.
Yeah, question one. And there isn't a lot of interactive polls with this. We have a lot of case presentations towards the tail end. So lots of interaction, but only a couple here on the poll. So this is just general poll question. Can a patient be in shock with a normal blood pressure? Yes, no, or just in case you didn't know, depends. Got a feeling we're going to have a majority of people like on one side of this.
Oh, I'm confident. Everyone's going to hit this out of the park.
I'm pretty confident. All right. Majority of people, I'm shocked. 88% say yes, you can have a normal blood pressure and a patient still be in shock.
Absolutely. Let's answer this question. You guys are absolutely correct. 88% of you guys are. Of what is shock? All right. So all this comes down to is that, again, remember, air goes in and out, blood goes around and around, and we need delivery of oxygen and glucose. If we do not deliver that oxygen and glucose, we have problems. So let's go to the cellular level for this. At the cellular level, if we're not delivering that oxygen, the cell goes to anaerobic metabolism, which means that they stop utilizing oxygen, which is very important in the creation with glucose to make ATP, the cellular driver, the fuel for our cells, okay? Lack of oxygen to the cell, anaerobic metabolism, okay? With anaerobic metabolism, when you don't have oxygen, you have a less efficient fuel production or generation of ATP. So with the glucose and oxygen, you can generate about 36 ATP. Without oxygen, you switch to anaerobic metabolism, which only produces with lactic production about 2 ATP. All right, so it's significant reduction. So with that, you don't have oxygen, you get lactate accumulation, and that lactic acid serves as an acid, and it's a poor energy source. And so it's less efficient. And then ultimately, you're going to get organ failure and death due to this process. Okay. So understand is that, again, we got to have a mode to deliver this oxygen and glucose, but also that oxygen needs to be available. So at the cellular level, anaerobic metabolism, accumulation of lactic acid, organ failure, death, all bad things. Lactic acid, some agencies out there that are progressive that have ISTAT capabilities measure lactic acid. And we measure this in the emergency department. And we use this as a marker of inadequate resuscitation. And it doesn't mean that it's just for sepsis, because a lot of times people hear this of a severe infection, a lactic acid, a severe sepsis, we're concerned. It can be in any situation where you have poor organ perfusion or shock that you get lactic acid accumulation. And what we see is the higher the lactic acid and associated with shock types or states, you have higher morbidity and mortality. So we can use that as a marker too, and some pre-hospital agencies are actually measuring this. All right, the perfusion cascade. This is a very busy slide, but let me break this down for you guys. Okay, at very top, we have organ perfusion. So let's use the brain for an example, okay? Organ perfusion is dependent on two things, supply and demand, right? So are we able to deliver that oxygen and glucose to there? And then what is the need for that oxygen and glucose for that organ? So let's just say the brain. The supply, to be able to deliver that, you have to have perfusion pressure to that. So we can use our mean arterial pressure, right? We got to be able to push that stuff forward. But then it is also going to be determined on the vasculature at that organ or the regional vascular resistance. And that's going to be determined on demand, right? So if you need more oxygen glucose, you want to promote more delivery, you're going to dilate that regional vascular resistance so it gets there easier, if that makes sense. That regional vascular resistance contributes to our systemic vascular resistance. So think about this as our arteries, right? That when our arteries clamp down, what does our blood pressure generally do?
Increase.
It increases, right? Well, our mean arterial pressure, as you see here, is determined by our cardiac output times our stroke volume, or systemic vascular resistance, excuse me. If you increase systemic vascular resistance, right, increase cardiac output, you increase the mean arterial pressure. But as you can see, that regional vascular resistance can affect the systemic vascular resistance. So this is all intertwined here. Cardiac output is determined by stroke volume times the heart rate, okay? The stroke volume, basically the amount of forward flow from the heart, how efficient that pump is determined by the preload, or the amount of blood plasma within circulation that's delivered to the heart. The contractility, how good is that squeeze of the heart? And then the afterload, which is the systemic vascular resistance, right? That is what that heart's pushing against. So as you can see, as your stroke volume, you increase your afterload, you're going to decrease your stroke volume because it's pushing against the more resistance. When you break this down, what you can really see is that, okay, we can have problems with vasculature. So our systemic vascular resistance can be a problem. We can have problems with the pump. So we look at our cardiac output, or we can have problems with volume, right? And it really breaks down to those three things. And when you look at volume, you think of preload, right? What is actually in the tank to deliver? So using that analogy is a way to look at this, but it's all intertwined and related, and it has positive and negative feedback on one another. So where does shock begin? Again, it can be a pump failure, right? The heart, the core pump of our bodies. It can be a volume problem, that you don't have that blood, the red blood cells or the plasma circulating to actually pump through the system. It can be a pipe problem. So when you think about this as the arteries, right? Either they're extremely dilated, you can't maintain vascular tone, right? Or it could be a blockage. You're actually occluding somewhere in this circuit and it's providing back pressure and you're not getting any forward flow. So when we break this down, right, pump failure is going to be a cardiogenic issue. Volume loss is going to be a volume issue. So hypovolemic, it could be hemorrhagic, or it could just be actually third spacing of fluid, et cetera. Your low systemic vascular resistance or a pipe problem, we think a distributive shock, and we'll get into this. And then flow blockage is an obstructive shock. All right. Now, I do want to preface this is that oftentimes these shock states have overlap. When we go through the cases, we'll do some in isolation, but some with overlap as well, and give you a guideline or a way that you can actually address these problems that is both therapeutic and diagnostic as well. All right. So as you guys correctly answered the question here, shock does not mean hypotension. All that means is that we have an inadequate delivery of oxygen and glucose to the cells. So it's a perfusion problem, and it's not a number. It's not the blood pressure we're looking at. We're looking at signs and symptoms of shock when we're treating these patients. And our body does a good job of compensating for this, right? So when we start to develop shock, we have natural catecholamine release from our adrenal glands that releases norepinephrine, endogenous epinephrine, cortisol. And that has systemic effects on our body to increase the heart rate, increase our vascular tone, to maintain perfusion to our vital organs, okay? Now, that compensatory mechanism can only keep so much to maintain a blood pressure perfusion, and then we start to see decompensation. Going back to this, though, the driver of that delivery of that oxygen and glucose to our cells is going to be determined by two things. Now it's the perfusion pressure and your oxygen delivery. And I want to nerd out on some of this math here. I know it's not everybody's favorite topic, but if you understand that there are some core principles involved here, hopefully we can make this make sense for you guys. So let's start with perfusion pressure. Okay. Our mean arterial pressure equation is our systemic vascular resistance times our cardiac output plus our central venous pressure, also known as the right atrial pressure. Now, color-coded with this, as you can see in the equation, the purple, the systemic vascular resistance, is our vascular tone, okay? Our cardiac output is determined by our heart rate and stroke volume. That's our cardiac output, right? And our CVP, we use this as a surrogate marker for our volume status, okay? Now, what about oxygen delivery? Well, as you can see here in this picture is the heart and lungs that you get deoxygenated blood returned to the right side of the heart, pumped through the lungs, it gets oxygenated, returns to the left side of the heart, gets pushed through the body to our organs. That delivery of oxygen then goes to those vital organs. And then depending on the demand from that organ, it extracts the oxygen and then the cycle continues. Well, we can measure that delivery of oxygen. There's an equation for this. And this is a lot of numbers on here, but there is a good takeaway from this. The delivery of oxygen is determined by your cardiac output. Again, it's in both the mean arterial pressure calculation, but also in delivery of oxygen, times the oxygen content. Now, the oxygen content here is what you see is HGB is the hemoglobin times 1.36, which is a constant, time our arterial saturation, plus the partial pressure of oxygen times a constant, which is 0.003. Okay. A lot of math, a lot of numbers. Take away from this that I want you to know. All right. The partial pressure of oxygen is that we can put somebody on oxygen and we can raise that partial pressure of oxygen, and we can measure that if we put an art line in and measure that from the blood, and we can put that up well above normal ranges, 300s, 400s. But what you see is it's time 0.003. That is not much of a factor when we look at this. But what does matter though is our hemoglobin. But what I want you to take from this equation though is that our oxygen content of the blood is largely determined going to be by our hemoglobin. If our hemoglobin is low and our oxygen sat is high, it doesn't matter as much as our partial pressure of oxygen. So if you put somebody on a pulse ox and it's reading 100%, but their hemoglobin is 3, we are not delivering that oxygen to those vital organs.
I think I think what you're trying to explain, right, is the fact of it used to be for shock, put your patient on 15 liters non-rebreather, and that was the gold standard, right? So what you're saying is sure, that's great. It puts oxygen into the blood, but with this equation, it doesn't really make a drastic difference.
Correct.
Right?
So what I would say is like you have a pulse ox on a patient is that yes, oxygen is good for the body. Okay. Oxygen is determined, it's 97% is transported on hemoglobin. And if you don't have the hemoglobin to transport that to the vital organs, that's a problem. So when you think about our hemorrhagic shock, trauma patients, or our GI bleeds, that their hemoglobin's low, yes, we want to put them on oxygen. If we're in a progressive system that has capabilities or access to blood products, those are the patients that need this because you need to correct that oxygenating carrying capacity, which is the hemoglobin problem, right? Rather just thinking it's like, well, I have them at 100%. I'll just give them more oxygen and that's going to solve the problem. But really that has little effect until we correct the hemoglobin. So, all right. So putting this together, again, cardiac output is in both the perfusion pressure calculation for MAP and also for oxygen content and delivery. So understanding is that we have to have that mode to deliver this, but the importance of making sure we have adequate oxygenation carrying capacity or hemoglobin available, the red blood cells, is also important as well for certain shock states. Okay. A lot of this stuff, again, this is very high level, but if you understand is that we got to maintain organ perfusion delivery. And then the brain and vital organs need 2 things: oxygen, glucose, and a way to get there. All right. So recognition. How do we recognize shock before we even get a set of vitals? Okay. Number 1, I want you to think about is mental status. And this is part of your walking into the room of sick, not sick, right? And just interacting with the individual. Do they appear anxious? Are they confused? Are they obtunded? So get an idea of their mental status. Oftentimes is what you see is, do you guys recall, question is that what are one of the earliest signs and symptoms of shock? I'm going to alter mental status, confusion, right? Agitation. And so you guys have all seen this case of somebody who's actually in shock that's agitated, altered, and a lot of times it's get misconstrued as like they're intoxicated. It's like, no, they're actually profoundly hypoxic, or their blood pressure is tanked and they're not perfusing well, right? And so mental status is going to be one of the first signs and symptoms to be looking at. Next is skin exam. So is it warm extremities? Is it flushed skin? You should be thinking of distributive shock, and we'll get to that. Is it cool mottled? You should be thinking that you're not having good perfusion to those extremities and there's low cardiac output, right? This is a picture here showing mottled skin. I'm sure we've all seen that before. We want to assess pulses, both central, so femoral pulses, carotid pulses, and then peripheral radial or DP pulses in the feet. And also assess cap refill. Now, assess cap refill, this is just an example of how you do this. You just depress the skin. You're basically pushing the blood out from the capillary refills, the capillaries, and you're seeing how quick that refill. And you count how long that takes. Anything greater than 2 seconds is poor capillary refill. Now, there's better evidence to be sent is checking not only peripheral capillary refill, but also central capillary refill. And the process is exactly the same as you would do in this picture here. But this will give you an idea of like distally, their peripheral perfusion, there's poor cap refill, but centrally they have good cap refill. And think of this as like checking your radial pulse versus a central femoral pulse. All right, your lung exam. Now, I add this in there as you do your algorithm, as you're differentiating between shock states and then also treatments for this, is that we want to know what their lungs are doing, because that can give an idea if this is cardiogenic or possibly obstructive process. Is, are you hearing fluid on the lungs, right? So do a good a pulmonary examination, listen to those lungs. Do you hear crackles or rails suggestive of pulmonary edema? Is there absent lung sounds, right? With the setting of potential trauma or a spontaneous pneumothorax, suggestive of a pneumothorax here, right? So listen to the lungs. Now, JVD. So JVD stands for jugular venous distension. Did you ever learn about JVD? Yeah.
A little bit. Yeah.
And so what this is that you have the patient at about a 30% incline, and you're looking at to see if the jugular vein is distended. If that's distended, that's suggestive of volume overload or potential obstructive process, meaning that blood returning from the heart from the venous side is backfilling up into the neck because it's impeding forward flow. And that is either due to poor pump, that the heart's unable to push it forward, or there's an obstructive process, meaning that blood physically can't go forward, so it's backing up. This can give you an idea for volume status. I would add in here too, now it's not a clear cut just because this is there that this means, but looking at peripheral edema as well, right? And the thing that always comes to mind in this is somebody who's in decompensated heart failure, right? They're fluid overload, you see JVD with this, and they have peripheral edema. And all that is that you get third spacing of the fluid into the lower extremities because it's more gravitational dependent. And you can push on the extremities and it indents, right? So that would be peripheral edema. So looking at that in addition to JVD, and it gives you an idea of volume status. Now, if you have certain shock states and those neck veins are completely flat, right? That could be a sign that this is not an obstructive process or cardiogenic process, and this could be a tank problem. Like maybe their tank's not full, they're hypovolemic for whatever reason. And so this is just a picture showing how to assess for JVD and actually measuring it. But what you're seeing there is that's the external jugular vein. And you can see how engorged that is due to backup pressure. And lastly here, this is something we often don't have in the pre-hospital setting, but Foley catheter is actually measuring urine output. But if you think about this, is that when you're in a state of shock, you decrease perfusion to the kidneys, and the kidneys is going to decrease in function, but that's also going to decrease the urinary output or production of urine. You can use that as a marker of resuscitation as well, as that you start to resuscitate some, they're making urine, it's like, we're perfusing the kidneys well, therefore we're heading in the right direction. So this is even before you put on the monitor, signs and symptoms to be looking out for shock. I think that this is a very high impact slide and something to really know. Again, if you do a really good history and physical exam, you're going to have 90% of your diagnosis right there. So talk to your patients, examine your patients. All right. We do need to understand the difference between compensated and decompensated shock. Compensated shock, again, when we start to have poor perfusion to our organs, we have that intrinsic catecholamine release, and our body is going to try to maintain that perfusion. All right. What that does is that you're going to maintain a normal blood pressure, but you're going to see some symptoms or signs or vital sign changes that we're compensating. One of those being increase in heart rate, right? Remember our equation, heart rate times stroke volume for cardiac output, right? Is that heart rate's going to go up to try to maintain mean arterial pressure. So tachycardia. Well, we can start to see some signs of decrease in perfusion. What that'd be is cool extremities, anxiety, again, that mental status, and start to see a peripheral delayed capillary refill. As this progresses, this is the spectrum, then we tip over into the decompensated shock. And now this is where we start to see the hemodynamic changes, but also the end organ damage that's associated with poor perfusion of those organs. So this is where we have increase in altered mental status. We have modeling of the skin and weak peripheral and central pulses. And ultimately, if this is not intervened, we have irreversible end organ damage and multi-organ failure and possibly death. This is what's so critical about this is we want to identify and intervene at the compensated phase rather than them getting to the decompensated phase and being behind the 8 ball here. Keep in mind, pediatric patients particularly are really good at compensating until they're not. So they will fall off this cliff a lot faster. It's not a gradual decline. It can be that they're compensating, and then they are unable to compensate anymore, and then they crash. So understand that this is a spectrum, but we want to intervene when the patient's compensating and identify that shock early. Now, how do we incorporate our vital signs into this? Because it's not just a physical exam. We need to use our tools. So I hate when we talk about systolic blood pressure as a marker of shock. That drives me nuts. When somebody comes in is like, I have a patient, a heart rate of 130 and a systolic blood pressure over PALP. It drives me nuts because our mean arterial pressure, which is a better surrogate marker of what we're actually perfusing our organs with or what our body's seeing, is by this equation here, which is the systolic blood pressure plus 2 times the diastolic blood pressure, all divided by 3. And what this means is our diastolic pressure is twice as important than our systolic blood pressure. All right. And if we're just reporting our systolic blood pressure, we're missing a whole lot of information regarding this patient. Okay. Now, keep in mind, we spend 2/3 of our time of our life in diastole. So why are we just reporting a systolic blood pressure when we give patient turnover or report here? So I'm a bigger fan of utilizing the map, and majority of the monitors out there actually give you a map versus you have to calculating. So I want you to understand this equation, but you don't need to calculate this. A lot of times this is automated for you. And just like everything for vital signs, the trend's more important than just an isolated vital, okay? Another pet peeve of mine is when somebody says they get a set of vitals and they report vital signs stable, but they have one set of vitals. We don't know if that's stable at all. It's the trend that matters with this. So utilize MAP over just blood pressure and look at the trend that these patients are going in. Another really important vital sign that we can actually calculate is shock index. And I hope that all you providers out there are actually utilizing the shock index. There's really good data coming out about how this is better at detecting occult shock, even when this says the systolic blood pressure looks okay. The calculation for shock index is just the heart rate divided by the systolic blood pressure. A normal shock index should be less than 0.7. But as this is showing here, if you see the heart rate greater than the systolic blood pressure, be concerned. That's easy because if you just have a shock index of greater than 1, be concerned about that patient. That is occult shock until proven otherwise. they have my attention a lot more, and I'm going to follow that patient a lot more closely as we start to intervene and resuscitate that individual. But also look at that too, as like, it might be fine as you come up on a patient who's 50 years old, they have a heart rate of 120 and a systolic blood pressure of 100. And you're like, oh, that doesn't look bad. But then understand they have a history of hypertension. They walk around with a systolic blood pressure typically of 180. That's not good. So that patient I'm watching a lot more closely and saying there's possibility of occult shock here. Now, what about pulse pressure? If you're not familiar with what pulse pressure is, all that is the difference between the systolic blood pressure minus the diastolic blood pressure. This can be used, and what we'll see on the coming slides here, to help differentiate between different shock types. Because again, you spend 2/3 of your time in diastole, that diastolic blood pressure is very important. But let's say that you have somebody that was stabbed, they're bleeding out. Not a brain buster about what's going on. This is hemorrhagic shock. What you see with their blood pressure is their systolic blood pressure is going to drop because the tank is low. Their diastolic blood pressure is actually going to increase, and you're going to get a narrowing of their pulse pressure, the difference between the systolic blood pressure and diastolic blood pressure. Because the problem is the tank, meaning there's nothing in the tank. But that vascular tone, which is maintained by the arteries, is still intact. So that diastolic blood pressure can still try to compensate for this, and you get a narrowing of the pulse pressure. So if you're not familiar with this, this is another tool that you can use when you look at your vital signs and you're differentiating between the types of shock to help say is this is more consistent with a distributive shock versus a hypovolemic shock, cardiogenic shock, or obstructive shock. And lastly is end-tidal CO2. The sixth vital sign, in my opinion, is that we should all be utilizing end-tidal CO2. End-tidal CO2 is measured by the exhaled CO2. We can measure this either with a nasal cannula. We can also put this on like a measure for like an iGel or a definitive airway with an endotracheal tube. It's a direct measurement of the patient's ventilatory state, but it's an indirect measurement of the perfusion state and metabolic state. And what I mean by this, in shock state, we're worried about the perfusion. So what do you suspect that the end-tidal CO2 is going to be if somebody's in shock? Low, because you're not actually able to circulate that CO2 to actually breathe that off. So another thing here is that your lungs are going to be compensating for certain shock states too. So you're going to hyperventilate, which could also drive that CO2 lower as well. So important things that we should be utilizing with our standard set of vitals, shock index if you're not using it in end-tidal CO2, and then keeping in mind of what is that pulse pressure doing is when you're differentiating between us. But the monitors do not calculate a pulse pressure for you, but majority do calculate a map. But again, utilize a trend.
Will you, so like leave this slide up for a second, right? We're looking at a couple different calculations, most of which probably for newer providers is not super familiar to them, right? So can you weigh, like, we know what the protocol says, we know what our normal routine patient assessment algorithm looks like. Now you're talking about adding some mathematics into that, right? So how do you weigh, these are important calculations to, I think, understand shock at a deeper level, to recognize shock at a deeper level, instead of just like the cookie cutter medicine of like shock, not shock, right? So how do you weigh like mathematics and patient application in the field? Like, how do they work together?
I think the first key thing that we need to stop doing is saying this isn't shock until we see a low systolic blood pressure. And we always say a systolic greater than 90, right? We want to hit that systolic. So steer away from that. I will say is if you got to follow protocol, but understand shock's a spectrum. It's not black and white. It's not shock and shock. So remember the slide of the physical exam signs, symptoms that you will see before we start to see the hemodynamic changes with this. But utilizing the shock index and end-tidal, those things can be used before we start to see changes in the systolic blood pressure and the mean arterial pressure. That's how I would utilize this, of saying, I'm worried that this patient is in compensated shock and may progress to decompensated shock unless we intervene now. And that's where you want to intervene before you wait for that blood pressure to drop, before you wait for the patient to go from anxious to agitated. And now we can't get IV access, and so we want to be proactive and not reactive in this. So I hear what you're saying is that, yes, you're probably going to have specific things in your protocol that say, we do not start a vasopressor until hemodynamics hit X. But what you can do is initiate that resuscitation before with IV fluids, and then say, I have a vital sign that's trending this way, and prep your vasopressor to be going should they drop below your protocol limit to say, this is when we start initiating this. So the way that I utilize this is yes, you're going to get your standard set of vitals. Don't use just a systolic blood pressure. Use your mean arterial pressure. Follow the trend. And I feel shock index and end tidal CO2 are really good at identifying the occult shock that you don't see that low map yet, but they might be trending in that direction and utilizing it to intervene early.
Right. And it's understanding the pathophysiology of what is going on. This is not just we're not talking about a basic level of understanding. We're talking about how to understand shock at a more advanced level, recognizing the pathophysiological changes prior to what maybe you learned in your generic EMT class.
Yep. All right. So your pre-hospital toolkit, again, 90% of your stuff is going to come from history, right? And physical exam. So obviously you're still going to, what's the history here? What medications are you on? What allergies, et cetera? Utilize your physical exam, which we talked about here, okay? Know the vitals, right? Utilize the map, utilize the trend, utilize your shock index and end tidal CO2 to help determine that earlier occult shock. But also as you initiate resuscitation, you should be seeing changes in that as well to follow along with and trend this. Now, I do want to make a little plug here for progressive systems that have the capability to utilize this. There is a role for ultrasound. That I do see that there is a role for pre-hospital ultrasound. And this is one of them, is helps you determine between different types of shock and also help identify potential intervenable pathophysiology. So one of those particularly being in trauma is a pneumothorax. This is actually pretty sensitive. This is very sensitive ultrasound as detecting as if there's a pneumothorax here. However, we can utilize our physical exam and presentation and know when do we need to intervene in that same situation. This is also really good at looking at the heart and seeing, is there pericardial tamponade or fluid around the heart and identifying that pathophysiology. It's also good to utilize for volume status of the patient as well. So I do see that there is a niche here in pre-hospital EMS for progressive systems to utilize and implement this. I don't want to spend too much time on this, but I do want to put this out there is that there is utility for ultrasound, particularly when it comes to undifferentiated shock and management. All right, classifications. Okay, so now let's get to the meat and potatoes here. The 4 types of shock. So we've seen this picture here, right? Cardiogenic, pump failure. The pump is not working. When we think about the differential for this is that, I think a lot of people think about heart failure. That muscle is fatigued. It just doesn't get any forward flow. But it could be acute things too, like a valve rupture. All right. It could be an arrhythmia, whether an unstable bradycardia or an unstable tachycardic rhythm that we need to intervene right now because that heart cannot put forward flow due to the rhythm it's in. Right. It can be a myocardial infarction, a heart attack. Right. It causes heart damage, poor flow. So pump failure, differential falls under cardiogenic. That pump is not working. Okay. Hypovolemic volume loss, right? So this can be hemorrhagic, right? Whether this is trauma related, GI loss, et cetera, can be due to dehydration, just poor intake. Burns is a good one, or third spacing from burns is another one that can result in volume loss, or third spacing just in general too. Distributive. So this is the vascular problem, right? We cannot maintain vascular tone, and it has a broad differential. The most common that we see to do this is due to infection, anaphylaxis, and then neurogenic is what we'll talk about well in a subtype of distributive shock. That's just, you cannot maintain that vascular tone. And then lastly is obstructive, right? There is a physical blockage preventing forward flow, whether that is a massive blood clot in the lungs that's preventing the forward flow, whether this is a tension pneumothorax, so increased intrathoracic pressure from a deflated lung that's putting pressure on the mediastinal structures, or fluid around the heart that prevents it from actually filling and squeezing to have forward flow. So a physical obstructive process that's preventing this. These next 2 slides are really, I feel, high impact and have a lot of information. And if you can conceptualize these slides, then you're going to have a good approach for how do you classify and address this shock. So when you think about shock, it gets separated into distributive, cardiogenic, obstructive, and hypovolemic. And our equation is at the bottom. Mean arterial pressure is our systemic vascular resistance times our cardiac output times plus our CVP or our volume status, right? So distributive, we talked about, it can be separated differential here. Septic, so infectious etiology. Neurogenic, it's actually a nerve problem. Anaphylactic, which is a distributive shock due to histamine release, and you get vasoplegia. Those arteries can't not contract. Also hits a lot of other stuff, or adrenal insufficiency. For our cardiac differential, right? So think this person's having a heart attack. Are they in an unstable arrhythmia? Is there a cardiomyopathy, heart failure issue? Is there a valve problem? Obstructive, again, tension pneumothorax, fluid around the heart, or a massive blood clot in the lungs. And then hypovolemic, whether this is fluid loss, hemorrhage loss, third spacing, et cetera.
I think this slide right here, if you're brand new EMT or even an EMT student, a screenshot of this right here could go a long ways, right? Because just understanding shock, what it is, the categories it's broke down to, and then what are the causes in those individual categories, including your map like this right here, a one-stop shop, screenshot this right here and use this to truly dive deeper into each one of those causes, I think is a phenomenal,
Absolutely.
Phenomenal tool.
All right. Now, this slide here for the undifferentiated shock, and we're going to give you a pathway as we go through the cases on how to figure out what shock state might be contributing to. But this is a good way to both diagnose and manage. Number one, you should be looking at is the patient's volume status. All right. So the CVP, we don't measure CVPs in the pre-hospital setting, right? But we need to ensure that there's adequate circulating volume. Every patient, even if they're in florid heart failure, EF of 15%, fluid overload, or end-stage renal disease, don't make urine, they tolerate small fluid boluses. So you could always do a fluid challenge at 250, maybe up to 500, but you're not going to harm with a fluid challenge. Now, if there's fluid, obviously they're fluid up or fluid overload, don't give them fluids. But we need to assess the tank, right? We need to ensure that there's circulating volume. Okay. Once we've done that, they're still in shock. Then we need to address the vasculature. What are the pipes doing? And so if there's vasodilation because they're septic, they need a vasopressor, right? If they're in anaphylactic shock, they need a vasopressor to maintain that vascular tone. Is this neurogenic shock? We need to address that vascular tone. So ensure circulating volume, address the vasodilation. We address those that are still in shock. Look at the heart. What's the pump doing? Is this pump failure, right? Is this because they have an EF of 15 and they actually need a little beta agonist with a little epinephrine that might help in the situation? Is this actually because they're in an unstable atrial fibrillation with RVR and we need to be thinking about synchronized cardioverting them out of that because they cannot actually have any forward flow because it's in a tachycardic dysrhythmia, right? So again, if this is undifferentiated and you don't have a clear pathway of what this is, sure circulating volume, address any vasodilation, address the pump. All right, this is now a table, another good slide to help just categorize. Now, I do need to make the caveat to this that there are a lot of cases that are going to have overlap. So nothing in medicine is black and white and fixed perfectly into a box. But when we talk about these strict categories here, you can go through here and see it's like for hypovolemic, right? This is due to no volume in the tank. They're going to be cool, possibly pale, possibly diaphoretic. They're going to have flat neck veins because the tank is low. Heart rate's generally going to be up. Their lung sound should be clear. And that pulse pressure, because that vascular tone is still being able to maintain, that diastolic pressure should be high. So their pulse pressure gets narrowed. And at the very end, as you see there, elevated diastolic blood pressure. For cardiogenic, cool, often cyanotic, often have JVD, so descended jugular venous distension. They can have an increased or low heart rate, depending on. If this is left-sided heart failure, you can have fluid in the lungs, so you can hear that fluid with crackles or rails. Pulse pressure, again, should be narrow because that vascular tone is not the problem. They should be able to raise that diastole, and their diastolic blood pressure is elevated. For obstructive process, cool, pale, JVD is often present because this is an obstructive process, putting backup pressure. Their heart rate's generally elevated. Lung sounds, depending on if this is a tension pneumothorax, that could be absent on one side. If it's a pericardial effusion, lungs are often clear. And then if it's a massive P, lungs are often clear as well. And pulse pressure should be narrow as well. And the diastolic pressure should be preserved. Distributed shock, this is where we see a difference. Warm skin, generally early, flushed, flat neck veins. Their heart rate generally is increased. Their lung sounds are generally clear. Pulse pressure starts to widen because you cannot maintain that vascular tone. So that diastolic pressure drops. Okay. So looking at this slide, we can say skin warm, wide blood pressure, and or low diastolic blood pressure. We should be thinking low SVR. This is a distributed etiology. That's our differential we're going to be going on. If we're looking at the skin's cold, we have a narrow pulse pressure. We're thinking this is low cardiac output. We should be saying, what's their volume status? Is there JVD? Is there peripheral edema, et cetera? If it is, then we're going to be thinking cardiogenic and obstructive. And then we're looking at our physical exam findings to suggest either one. All right. Flat neck veins, low tank, think volume. Okay. So this one can help guide you as you think through this with the associated physical exam findings on there. All right. Let's briefly talk about the resuscitative medications before take a break. IV fluids. So we all carry IV fluids. I think that this is an always ongoing battle of what's best. Normal saline, lactated ringers, plasma light. I will say that between normal saline and lactated ringers, because these are the most common IV fluids that EMS carries, lactated ringers wins. With the caveat that normal saline, because it has a higher sodium load, is generally better for traumatic brain injuries. So if you're treating a TBI patient that needs fluids, go with normal saline. It is also compatible with blood product administration. So if your system carries blood products, then normal saline is generally going to be what is carried along with that as well. Lactated ringers is better because it is more physiologic, but it is not 100% physiologic. So as there's nothing normal about normal saline, it doesn't mean that lactated ringers matches our blood content perfectly. So as you can see here, the sodium content is about 130, which is a little lower than what our circulating sodium is. Chloride's about similar. Potassium it does contain, which is about there as well. On the lower end of where our normal potassium is, it does carry some calcium and lactate in there. It is best for sepsis, septic shock, trauma patients, hemorrhagic shock, and burns. All right. Even for the reason is that high normal saline, that chloride load and that saline load can make somebody acidotic, which is bad. And that's with large volume administration with this. It is also can worsen acute kidney injury or affect the kidneys of large saline loads as well. So lactated rings are generally better. Long story short, if you carry IV fluids, lactated ringers over normal saline unless TBI or if this is administered for blood product administration. All right, let's talk just briefly about the inotropes and vasoactive medications. This is a busy slide. Majority of the agencies out there, if you do carry any vasopressors, it's going to be epinephrine and or norepinephrine or both. The medications that are shown in the center of this slide, on the far end is phenylephrine, on the far right is isoproterenol. And what you can see is that the alpha and beta effects here is that there's no clean drug here, that it just has alpha effects or beta effects. Now, alpha receptors is in our smooth muscle, okay? This is on our arterioles that when we have a pure alpha, that causes vasoconstriction, okay? Maintains that vascular tone. It's also in our eyes and it's in the GI-GU sphincters as well that cause contraction. But the main thing I want you to think of, when you think of alpha receptors, think vasculature. Beta 1 receptors is the heart, okay? So that's going to affect the contractility, but also increase heart rate. Beta 2 receptors are the lungs, and that is going to cause bronchodilation of those smooth muscles. So norepinephrine is what you see here. It does have alpha effects and it has little beta effects. So it's going to act more on the vasculature than it is on the heart and lungs, where epinephrine is a little more dirty. It's going to have more beta effects, but still has the alpha effects, and it is dose dependent. So just understand where these receptors are, where the medication that you carry acts on in the body, and then know that that is going to ultimately have effect on what medication we choose for what kind of shock. So the two, again, that EMS agencies most commonly carry are going to be epinephrine and norepinephrine. Now, we typically put this in, again, follow your protocols. For MAP less than 65, we should be considering vasopressors, if not fixed with IV fluid administration. So epinephrine has effect on alpha, beta 1, and beta 2. Norepinephrine has more alpha 1 than beta 1 and minimal beta 2. And when we talk about our shock types, right? So in purple here, we have our distributive shock types, and we have our vasopressor of choice. So for distributive septic shock, we are generally reaching for norepinephrine first line. Okay, that's again, after IV fluid resuscitation, norepinephrine is what we go for. Neurogenic shock, and we'll get to the reason behind this, is a distributive shock as well. And norepinephrine, because we want primary alpha on this to restore that vascular tone, is going to be the medication we reach for first. Anaphylactic shock. So treatment of anaphylaxis, what are the first three treatments? Epi.
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 Epi. Nice job.
Epi.
Good job.
So just as the vasopressor you would reach for, epinephrine. All right. And that's because in anaphylaxis is dirty. That mast cell degranulation, all that stuff, it affects the whole body, that it's affecting lungs, heart, vasculature. So we want to hit the beta 1, beta 2, and the alpha. So epinephrine is going to be what we go for.
So again, we just said again, so epinephrine catches both alpha as well as beta 1 and beta 2.
Beta 1, beta 2.
Like right in the mid, it takes care of all three.
Takes care of all three, right? And where norepinephrine, primary alpha, little beta 1, like minimal beta 2. Okay. Cardiogenic shock. Now, if they're in cardiogenic shock and they have a normal heart rate, we should be reaching for norepinephrine. Okay. If they're in cardiogenic shock but bradycardic, this is where we want that beta 1 that epinephrine provides more. So cardiogenic shock, generally reach for norepinephrine. If it's cardiogenic shock, reach for epinephrine. All right. Now, this is not prime time, but I do want you to be aware of this because there are current studies that are undergoing that are looking at vasopressin, even in the pre-hospital setting. This is another vasopressor that has multiple different receptors that they act on within the body. There's good evidence for vasopressin as an adjunct to norepinephrine for distributive septic shock. And it's investigational right now in the setting of trauma and hemorrhagic shock. And I know what a lot of people are thinking, this is heresy to be saying giving vasopressors in traumatic hemorrhagic shock because what they need is source control and blood resuscitation. You're absolutely correct. However, that as that shock progresses in hemorrhagic shock, we start to see, again, nothing fits into a perfect box, but you start to see a distributive type shock that develops because you have all that cellular damage that impedes the vasoconstriction of the arteries. Now, this is not an acute shock. This is acute trauma. But as that trauma time progresses, we can see this start to develop, and there might be a role for vasopressin, particularly in this. So this is not prime time. This is something, if you want to nerd out, go read about vasopressin in the setting of shock and primarily of trauma, because I think that's where we're going to possibly be seeing this in the pre-hospital setting in the near future.